Hi, good evening students, welcome back. And the series of Farre, now we are going to do the important topics where we can attempt our theory exam properly and also be somewhat smarter in our vivas. So we are discussing two topics today, endometriosis and fibroids, and both are generally coming into exams. Endometriosis and fibroids, I know upfront, let me tell you, both are because of high estrogens. Women having more amount of basal estrogen are going to have these problems. So, it's here itself that you should understand that the basic treatment in both of these is to reduce the estrogens. Both of these diseases are present in a woman till she is around 50, and after that they start reducing. You must understand these fundamentals, that it's because of estrogens, and once the estrogens are reduced after 50 years, they will become better. But now the woman is, let's say, 30 years and she's got endometriosis, she's got fibroids. Then how is she going to become better? You cannot wait for menopause, it's still 20 years. So whatever treatment we give, we are trying to basically reduce the estrogens. Yes, that's why we always teach you to correlate things. That's what we are telling you in PW always. Please correlate, become smarter doctors. So how do you reduce the estrogens? We give combined oral contraceptive pills. COCPs, one of the non-contraceptive benefits of COCPs is that if a woman takes them for 5 years or even 10 years, then she'll have lesser endometriosis and lesser fibroids. We've understood a little bit of these two diseases even before we started our discussion. Right. Good evening. Yeah. Good evening, everybody. Practical aspects of management. That's what we are doing all the time. So, staying in touch with what Dadu is saying. Come, Dadu, I'll show you practical stuff. Right on. See this? This is endometriosis. This is how endometriosis looks like. When you look at the uterus and the ovaries, I'll show you normal ovaries and videos about them. See this is the uterus here. These are the ovaries here. Both the ovaries are having the chocolate cyst. So we are discussing endometriosis first, and in this you will see this chocolate cyst, and these two ovaries are so heavy in the pouch that they are kissing each other. That's why you see kissing ovaries. Yes, you see kissing ovaries in cases of endometriosis. The ovaries are so heavy and full of endometriotic fluid, which is basically brownish in color, which is menstrual blood basically. So that's why we call them chocolate cysts, which are both sticking to each other, kissing ovaries. See this? Yes. Look at the the uh, adhesions here. I want you to concentrate on the adhesions and look at the tubes here. Look at the tube here. See, the tube is so badly kinked. So if a tube is so badly kinked, it is like this. It is supposed to pick up an egg. So if the tube is kinked somewhere behind like that, you saw the angulation in that tube. If the tube is so badly kinked, you think it is going to catch the egg properly? See, the egg is supposed to be here. Sorry. See, the egg is supposed to come out from the ovary and the tube is supposed to pick it up. Ovulation and pick up. But the tube is so badly kinked. How do you think it's going to pick up an egg? That's why infertility in endometriosis. So yes, let us see about endometriosis. Endometriosis basically is ectopic endometrium, and the main etiology is the Samson's implantation theory of retrograde menstruation. So if you see the uterus and the fallopian tube here, so what happens every month? Every month the woman menstruates and the blood has to come out from the cervix. So when the uterus is trying to push this blood out by contractions, I'm trying to show you my hand like the uterus and the cavity as, and this part as the cavity of the uterus. So when the blood sheds because of the progesterone withdrawal, the shedding of the endometrium has happened. Now uterus will try to push this blood out. Then only the cervix will open. The contraction of the uterus will open the cervix. Now those contractions will take some time to open the cervix. Before that happens, some blood will go ulta, retrograde, and deposit over the ovary. Yes, and then it will deposit over the bowel. It will deposit over the ligaments. So these deposits, all these deposits, these are the deposits of endometrial glands. The endometrial blood is not RBCs alone, isn't it? It has got endometrial glands. So those glands go out and they get implanted in the pouch of Douglas, on the ovaries, bowel, and the ligaments. Now what happens next month? This month the implantation happened. Now next month what happens? She's going to menstruate again. So let's see. She's going to proliferate. She's Now, she's going to proliferate every month. Next month, when she proliferates here, she's going to proliferate here also. She's going to make the endometrium secretory here. The same endometrium which was here in the ligament will become secretory. This will have shedding and this will also have shedding. But this has a place to go out and cause menstruation. But this has no place to go out. So this becomes a bigger and a bigger deposit. So this on the ligaments or on the bowel surface, on the tubal surface, on the on the surface of the ovary, all of these places, these deposits go on collecting more and more endometrial endometrial secretions. That is basically the endometrial blood. So that is what is going to cause a lot of pain also to her. So that is what I showed you just now. The first thing I showed you was the look of the endometriosis. So that's how it happens. The implantation of these glands outside the uterus because of retrograde menstruation by the Samson theory. All right, and then these places become, all these places will become ectopic uterine, ectopic uteruses. Yes, they'll become ectopic uterus. So that's why she's not only menstruating here, she's menstruating in all these deposits also. That is what is endometriosis. Very painful condition and also causes severe dysmenorrhea, causes infertility. It's a big problem. All right. Most confusing part is endometriosis and endometrial cancer. Please give clear concept. There's nothing to get confused about this. If you have to understand between endometriosis and endometrial cancer, these are totally outright different. It is like, what is the difference between oral cavity cancer and rectal cancer? That kind of question you've asked me. So good you asked me. This is the place. Please, endometrial cancer is in the endometrium. Ectopic endometrium outside the uterus is endometriosis. That's all. endometriosis कोई कैंसर नहीं है. एंडोमेट्रोसिस में कोई कैंसर नहीं है. तो जो डाउट आता है जरूर पूछो यार. हमेशा याद रखो कि never a doubt is bad, because if you have a doubt, it will stay till the exam and you will get into a problem. So very good. Understand, endometrial cancer is cancer of the uterine cavity. We are talking about that in somewhat more detail later when we discuss about C cervix and C endometrium in another session of Farre. Right now we are just discussing endometriosis. So endometriosis is ectopic endometrium, endometrial glands outside the uterus. Bas itna yaad rakho. And they start behaving, all these places start behaving like a uterus. To understand that, and then things become easier for us. So endometrium also goes through these tubes, retrograde, all that I told you just now. So now let's see, 70% to 90% all women have retrograde menstruation. You know what, that when we discuss about this retrograde menstruation, which is the cause, the Samson theory, which is the cause of the endometriosis, you know how many women have this blood going ulta? How many women in this world have this retrograde menstruation? Almost 90% women have this blood going ulta and getting deposited in this pouch of Douglas or on the ovary. So 90% women have endometriosis. No, the blood goes retrograde and it deposits in all these places. But in a few women who have more estrogens, they will make these areas grow in size and become endometriosis. Look, estrogen and progesterone in the body, it is present not only in the ovary and not only in the uterus. Estrogen and progesterone, which is coming from, I'll make another diagram for you to understand this. Ovary, every month the ovary is making a follicle. Follicle is first making estrogen, then making progesterone. You know that, E and P, E plus P, it is coming from the ovary. Now this doesn't go straight to the uterus like this. No, it doesn't do like that. The estrogen progesterone from the ovary goes into the circulation. So from the circulation all over the body, the estrogen progesterone is present. It comes and acts onto the uterus. Now that estrogen progesterone will also act all over the body. And in the body, there are glands of endometrium outside the uterus. So these places also will be acted upon by the estrogen and progesterone. That's what is endometriosis. The blood goes ulta, glands get deposited, and in these places they start to grow. That is what is endometriosis. Now, how many women have this blood going ulta, retrograde? It is there in 90% women in the world. But not 90% women have endometriosis. Only 10% women in the world have endometriosis. Those women who have high amount of estrogens, they will proliferate these deposits. And when they grow, they become endometriosis. Yes, those 10% women who have high estrogen and poor immunity. Two lines. High estrogen, poor immunity. High estrogen, poor immunity. Remember that. High estrogen will proliferate these deposits. Poor immunity cannot clear these deposits. That is what is the basis of endometriosis, right? So we are talking about that only, that 70 to 90% of all women have retrograde menstruation, but 10% of women who have poor immunity and increased estrogenicity. Remember these two words, the punchlines: poor immunity and increased estrogenicity, that is increased estrogen in the body. So poor immunity does not clear these deposits which have happened, and poor immunity poor immunity does not clear these deposits, and increased estrogen will proliferate these deposits more. All right, so 10% women have endometriosis. Okay. Look, can we just do the adenomyosis part a little bit later? We are doing endometriosis right now. A lot of people don't know this first. Okay. So, adenomyosis is something else. First, you understand this. So, when we have this endometriosis, it's basically, we'll quickly go through the basics and then I'll take your doubts. Okay, we'll do that. We'll go through the basics. That's what we have to do first. So, we are not going to do a detailed class. We are going to prepare you for the exam. So, what you have to write in the exam, what is coming in the vivas, all that we have to do. And spotters will come in endometriosis. Chocolate cyst pictures will come. They'll have a ovary with a cut section showing endometriosis. All that will be there. Okay. So, sites of presentation, most common site is the ovary, and the second most common site is the pouch of Douglas and peritoneal surface of abdominal organs. Now, deep endometriosis, lesion which is at least 5 millimeter beneath the peritoneum. That deep endometriosis is the reason why there is so much of pain. A lot of women have deep endometriosis. The lesion which is sitting over the bowel, suppose it is penetrating through the rectum and going into the rectal lining. So, she bleeds in the uterus 5 days a month. She bleeds through the rectum also 5 days a month because of deep endometriosis. This question came in MCI exam just now, 17th, 1 week back. Yes, exactly last week on Saturday this exam question came. What is deep endometriosis? It is already there in your app. Okay. So, yes, deep endometriosis is a lesion which is 5 millimeter deeper into the peritoneal surface, and it can present as nodule in the cul-de-sac, that is the pouch of Douglas known as cul-de-sac, rectosigmoid, and even the bladder, this deep endometriosis. Then rare cytodeposits, these deposits can be there in the lung also. Yes, the endometrial glands can go through the uterine circulation, through the veins. The endometrial glands can happen and find the way through the veins into the lung and deposit in the lung. So, she menstruates 5 days. She menstruates 5 days through the uterus. But that time when she is menstruating, there is a gland in the lung also, which is endometrial gland. So, she proliferates and secretes in the lung also. The day there is shedding in the uterus, there is shedding in the lung. She bleeds in the uterus, she bleeds in the lung. 5 days a month, she bleeds through in the bronchus, and she will have hemoptysis. She may have a deposit on the nose. So, 5 days in a month, she will have epistaxis. 5 days in a month, she may even have subconjunctival hemorrhage. So, these are the places: lung, eye, nose, and intestines, sometimes even in nipples. So, these are the places where there could be this implantation of glands outside the uterus, apart from the regular places like the bowel and the pouch of Douglas and the ovary. Apart from that also, there might be some areas like this where implantations can happen. So, these implantations which can happen, these will behave like uterus 5 days a month. These are known as the vicarious menstruation. This is known as the vicarious, excuse me, vicarious menstruation. Now, sometimes these deposits can be found on the scars also, scars of the cesarean section, the abdominal scar of the cesarean, not the uterine scar, abdominal scar of the cesarean section. It may be there in the episiotomies also. So, scar endometriosis, cesarean section scar and the episiotomy. There also you can see this endometriosis. So, basically what are the color of the deposits? I will be showing you a lot of pictures, but remember the first thing which I showed you in the lecture was the video of endometriosis. So all those deposits, what do they look like? That is what is the pathology. So they look like powder burn lesions. What do you mean by powder burn lesions? Gunpowder. Gunpowder, when it gets burned. You see the matchsticks in your house, when you burn them, the tip is brown. When you burn it, it is bluish blackish in color. So that is the powder burn lesion. So powder burn lesions or blue spots, we call them. Powder means gunpowder, okay, not just talcum powder, it is gunpowder. And chocolate cyst of the ovary, that is within the ovary endometriosis, there is chocolate colored fluid. And this uh, body will try to heal these deposits which are present. The body will try to heal them. Some healing will be there, although it is not as perfect as other women. That healing with adhesions, now that is also a very big problem of the endometriosis, because these adhesions, I was trying to show you in the beginning of the chapter that the ovary which is supposed to be under the fimbria, the ovary is stuck behind somewhere here because the adhesions. So there is altering of the tubo-ovarian relations, and adhesions can also cause a lot of pain because bowel may get stuck somewhere, and the the bowel movements also could be getting inhibited because there is extensive adhesion sometimes. So adhesions are a cause of that chronic pelvic pain in endometriosis. I've shown you those adhesions the first thing in the video. All right. So yes, let us see this normal pelvic anatomy first. I'll just try to help you with these videos now for you to understand. But before that, I want to see your doubts, because otherwise you will not understand. Endometriosis and adenomyosis, will come to it. Rishikaran, hi, how are you? Dadu, all of that is done. Yes, you are. They are just, the team is just finalizing the video, so don't worry about that. March 5th se pehle you will be able to have all the videos. By the time, the videos which are there, if you see them, you will already pass your exams. Don't worry, Dadu. Okay, can we just stick to the topic now, guys, everybody? So yes, this is the normal pelvic anatomy I'm showing you here. Normal pelvic anatomy first. Dadu, pay attention here. So this is the round ovarian ligament with the ovary, fallopian tube. This is the round ligament going into the deep inguinal ring. Lovely deep inguinal ring you can see here. So this is the normal pelvic anatomy. Now let us see a endometriotic cyst and tubal adhesion. See, this is the uterus, that is the round ligament there. The tube you're not able to see at all. There are so many. The round ligament is shortened because of adhesions. This round ligament is also shortened because of adhesions. Now can you see the right tube, the left tube? There are so many adhesions. See, barely you're able to see the tube. I am not able to see the tube properly at all. Look at this cyst. This is the ovarian cyst here on the left side, which has totally destroyed the anatomy here. See here the tube I have to take out from the adhesions. Can you see this? It took me almost 2 hours to correct the anatomy of this patient. This was around 2 years back, this video. So can you see the tube is in such adhesions? Can you see this tube here and see these adhesions? That is all endometriosis. And look at this ovarian cyst here, that is the other one. So that cyst I'll show you now. Now these are the adhesions again. The endometriosis causing all these adhesions. And this is the ureter in the adhesion. See the peristalsis of the ureter I'm trying to show you here. So look at this tube here. This tube which was supposed to be on the ovary. This tube is somewhere in the side in the pelvis. This tube, that's what I was trying to show you here. See this tube. This tube is not over the ovary. This tube is supposed to be on the ovary and pick up the eggs. Now tube is somewhere in adhesions here. That's why infertility is also a problem. Now these are the kissing ovaries. This video I had showed you in the introduction to this chapter. And look at these adhesions. Look at the kink tube, altered tube ovarian relations. So I'm in the middle of the surgery. I'm just making a video for my students so that they can understand what is the severity of endometriosis. Now this I'm trying to show you, I'm opening this one ovarian cyst I've taken out from the left ovary. See, I've done laparoscopic surgery, so all that it looking black to you because of me having done the cautery. Now look at this side. I want to show you the chocolate pouring out of the right ovary. Can you see that? Chocolate coming out of the ovary. That is the chocolate cyst. Of course, it will bleed when you're doing the surgery. So along with the chocolate, you're also seeing some strawberry forming, isn't it? Strawberry syrup also you're seeing. But yes, classically we say chocolate cyst of the ovary. Now see this, that cyst when I showed you, I'm bursting it to show you what is happening here. Yes, yeah, the chocolate fluid. Of course, when you do the draining of the chocolate fluid, after that you have to take out the cyst wall. Now this is what I want to understand here with this practical video, that when you're doing this treatment of endometriosis, basically endometriosis happens to young women. You cannot remove the ovary. So I have decompressed the cyst. You see this again. I've decompressed the cyst. See, the cyst is getting decompressed. I'm taking out the chocolate fluid. But I have to save the ovary. She's only 25. So she needs the ovary for her menstrual function and for having pregnancy. So that is the crux of endometriosis. That it is because of high estrogen she's having this. She's going to have this cyst. And when I take out the cyst, I leave the ovary behind because she needs the ovary for a normal estrogen. But she has the tendency of endometriosis. She is going to make a cyst again. Recurrence in endometriosis is the biggest nuisance. So what is the practical aspect of this chapter? The recurrence of endometriosis. That's what you have to understand. Endometriosis can go on recurring till the woman is having menstruation, because it is retrograde menstruation which makes deposits, and these deposits, you are taking out the menstrual blood to give her pain relief because the ovary is so big and cystic. You're taking out the menstrual blood. You will take out the cyst wall. After 6 months or 1 year later, she'll make another new cyst. Again, you will take out only the cyst. So that's what is endometriosis. It has a lot of recurrence till the time she is 50 and menopausal. Ultimately, menopause is the final treatment. Till then, she comes to me at 25 and she's here with me till 50 years of age. For 25 years, she'll be my patient. But yes, we can give her a normal life with surgical treatment and medical treatment. She can have a normal life, but she has to come and show me at least once a year. That's what is endometriosis. The recurrence is the biggest problem. To understand this topic, very interesting topic, condition which is there in 10% of women. So many young girls have endometriosis, and you have to tell them that I cannot remove your ovaries. Somewhere I was hearing treatment was given by some, I saw some students showing me a lot of sources where the treatment of endometriosis has been given for a 35-year-old woman to do a hysterectomy. Arey nahi yaar, hysterectomy won't be enough. The ovary is having the estrogen formation. So you have to do oophorectomy also. And at 35, if you do oophorectomy and hysterectomy, the woman will be menopausal and have all the side effects of menopause at 35 years itself. So hysterectomy is not the answer in endometriosis. Please understand. This surgery here itself, you understand, we will try to remove the disease but not the ovaries. You have to give her a normal life till 50 years. So this is what is endometriosis, right guys? So do they always need surgery? No. Surgery is not the every time management, but it is mostly the primary management for getting my diagnosis done. So we are coming to that part, okay? And LADES, I'm not talking about that, okay? Tajik Khatun, Tajik Khatun, okay? Please teach in English. ठीक है, Shubham Made, all right. So we will try to incorporate all the languages. Okay, so see the cyst, I am taking out only the fluid and the cyst wall, but I'm not taking out the ovary. See, I'm saving the ovary. That's what you have to understand. Chalo, now there will be a lot of peritoneal deposits also. The peritoneal, you look, the, oh, yes. See, the omentum is also having all these deposits. See these brown deposits in the omentum. I'm showing you at the liver. On the liver surface also there are deposits, but I don't think in the video you're able to see. Yeah, there's a deposit here. Right. So because of this, I think you understood the problem a little bit at least, because endometriosis is something you read a lot of theory, but till you see all these videos, one of these days, I don't know where you are, if you're interns and if you are medicos, if you're coming to Delhi, just give me a call and you can come to my hospital. If I'm doing the surgery, you're most welcome to come and see. So yes, symptoms are chronic pain, acute monthly exacerbation, present as severe congestive dysmenorrhea and dyspareunia. Now dyspareunia is painful sex, and this is classically deep dyspareunia. Deep dyspareunia. That is, one is penetration dyspareunia, that is while starting sex, while insertion, there is pain. That is because basically some women have vaginitis. But what is deep dyspareunia? Intercourse is established and the uterus and the cervix and the ligaments move with sex, and those ligaments and the uterus has endometriotic deposits. So that's why it's extremely painful intercourse. Deep dyspareunia and menorrhagia. So dysmenorrhea of the congestive type, and then dyspareunia and menorrhagia. Now infertility, I already told you, I gave you enough hints. Now we are just writing down altered tube-ovum relation, the ovary and the tube are not together, and there is decreased frequency of intercourse because of the dyspareunia, and poor ovulation. You saw the ovaries condition, poor ovulation, poor oocyte quality. So embryotoxic endometrial deposits, these deposits which are there, first of all, they'll make bad quality oocytes. If at all an embryo forms, that embryo will be affected by these by this endometriotic deposits. So poor quality embryos, reduce implantation and increase risk of abortion. All of these will contribute to the infertility in this woman. And the best diagnosis can be done by laparoscopy, but other things which will help us, array CA125 will help us in understanding, because it is not always diagnostic, but because CA125 increases also in CA ovary, but a high CA125 gives us a indication that she could be having endometriosis. Ultrasound is generally the best initial investigation to see that there is a ovarian cyst and there is let's say sometimes a hematosalpinx. All of that you can see, best initial workup, but not the overall best. Initially it is a good thing to do, and you can see in the ultrasound, yes, this is the transvaginal ultrasound. I had already made this the probe, the ultrasound probe is here, the TVS probe. This is the probe which is there and is showing us a view, and here you see the chocolate cyst. So this is what is known as the ground glass. This is what is known as the ground glass appearing cyst. Yes, ground glass. Now what happens, ground glass, you must be seeing a lot of glass panes around all of you. Through the glass pane you can see outside of your rooms, but there are some glass panes in the offices. You can see the glass, but they are foggy, you cannot see through them. You can see that vaguely somebody is walking, you can see the shadow, but you cannot see who is walking. That is what is a ground glass. So this is that ground glass appearance. Clear cyst, something like this will be this black color you're seeing, the clear cyst will be like that. But when there is blood inside the cyst, that is what is a chocolate cyst. It is a ground glass cyst. All right. So on the MRI, also you can get a very good imaging. So MRI is the best imaging. Always remember, in radiology, nowadays we don't say radiology, we say imaging, department of imaging, because radiology में क्या है यार, अगर आप अल्ट्रासाउंड करते तो उसमें भी इमेज है, और CT scan, MRI सब में imaging है, isn't it? So this is best imaging is MRI. In gynae generally we say MRI better than CT. Mostly we are happy with MRI, not as a absolute rule, but mostly what I say that MRI is the better investigation in radiology for gynae. So MRI. So that also will tell me, but the laparoscopy is the gold standard. Laparoscopy is the gold standard of diagnosing endometriosis, and this is what you have to write in your exams and even in your NEET PG and INICT exams. So ideally what we say, you do the laparoscopy. I've shown you many laparoscopy videos. Do the laparoscopy, and with the laparoscopy you see this cyst and the lesion. Then the cyst you're treating, before that cyst which you take out, you send it for the histopathology. So laparoscopy and histological confirmation, actually this is basically histopathological examination, the biopsy of the lesion. The histopathological confirmation is done. So laparoscopy and histopathology is even better than simply laparoscopy. Okay, I said laparoscopy and histopathology, that is laparoscopy and biopsy, is better than simple laparoscopy. So this is what I've shown you earlier also. Let's move on. So surgical treatment we've already discussed. I'm just now enumerating that. Chocolate cyst, you do a cystectomy. Adhesions, you do a adhesiolysis. And powder-burn lesions, those small lesions. Now those lesions you cannot, there might be 100 such lesions. You cannot cut 100 lesions on the bowel or on the uterus or on the the diaphragmatic surface. You cannot cut at 100 places or 50 places, but those places you can burn. So that is what is known as the fulguration. Fulguration of these lesions we can do. When we do the fulguration, we can do the fulguration by laser methods and by the thermal method. Laser and thermal methods, you can do that. Okay, now post surgery, I told you that she may come back to you with within 6 months to 1 year with another cyst and the recurrence of the problems, because she's a young lady. 25 to 35 is the peak age of endometriosis occurring, young woman. All right, so she may have endometriosis as early as 1 year or 6 months also. So what do? You have to make sure that she does not form these things again. So what is the reason she is forming endometriosis? Because of the high estrogen. So you can reduce the estrogen amount, and that is the medical management of endometriosis. So surgical management you understood very easily. Cyst है तो काट दो, adhesion है तो निकाल दो, और अगर powder burn lesion है तो जला दो. This you understand very well. But surgery is only the initial part. The biggest treatment of endometriosis is to maintain the state of normal ovaries and normal uterus with your medical treatment, and in this you have to suppress the estrogens so that you will have lesser menstruation and lesser endometriosis. And lesser estrogen means all these deposits in the pouch, in the ovary, in the bowel surface, all these deposits get lesser estrogen to proliferate. Sometimes we don't say lesser estrogen, we make her no estrogen kind of a patient. We reduce her estrogen so much, there is hardly any estrogen in the body, so she gets even much more better with the endometriosis. That is the medical treatment. So that is what is coming next. All right, guys, there's 60 to 70% recurrence. So medical management is basically to reduce the estrogens. Where is that? Yes, medical management is basically to reduce the estrogens. So we'll come to that, but let us first talk about the pain relief, medical management. NSAID is for the pain. To reduce the pain, we can give combined oral contraceptive pills will make the cycle anovulatory. So it reduces pain by anovulation, because anovulatory cycle is painless. First chapter, guys, menstrual physiology, first chapter, please see the app. Always I remember that is the core of gynecology. The first chapter, menstrual physiology 1, menstrual physiology 2. All right, so combined oral contraceptive pills will reduce pain, and they will also reduce the estrogen. Okay, so the disease also limited. So annual cycles are painless, and also it limits the estrogen because it has got, the patient has lesser estrogen in the body because of the OC pills. All right, right. So that is the basis, that you reduce the estrogen as the medical management. So I have told you only one drug so far. One is the painkiller, other one is the COCP. Giving COCPs on a 21-day regime, or sometimes we give continuous COCPs for 4 months and then only give a gap. So she gets periods once in 3 months, once in 4 months, like that also we do. But COCPs is that one very good drug which we can help the girls with. But what are the better methods, even better than COCPs, to reduce the estrogen? I'm just giving you an outline of treatment, guys. We are not going into detail. Actually, this is the basic outline of endometriosis. So yes, the other management is to oppose the action of estrogen. How do you oppose the action of estrogen? Give progesterone. So progesterone causes secretion of the endometrium and stabilization of the endometrium. So when you give this progesterone for a long time, it causes the atrophy of the endometrium. Continuous use of progesterone causes atrophy. The endometrium won't grow at all. So when the endometrium doesn't grow at all, because there is so much of secretion that there is no proliferation possible, constantly give progesterone, so endometrium becomes atrophy. So the punchline of the evening, remember guys, this is that punchline of the evening: atrophy of the endometrium in endometriosis. The word you're learning today with me, endometriosis. You need to reduce the estrogens. COCPs reduce estrogen, but better drugs are there like progesterone, androgens, GnRH analogs. They will stop the estrogen function altogether. So when there is no estrogen function, there is obviously no glands growing. When there are no glands growing, that means atrophy of the endometrium. So where all does the atrophy happen? Atrophy happens not only just in the uterus. See, the endometrium will be atrophic. There is no gland growing. I'm just making a lining. There is no growth of the gland. Okay. And the pouch of Douglas, these glands will become atrophic. Ovarian glands, they will become atrophic. Wherever there is endometrial glands, they need estrogen every month to proliferate. Endometriosis needs estrogen to proliferate. You make them lesser estrogenic places by COCPs, or inhibit the action altogether by giving high dose of progesterones. atrophy will happen. Again, I'll tell you atrophy in the next slides, okay? So progesterone causes atrophy of the endometrium. So the method of giving progesterone is by the depot-medroxyprogesterone acetate, that DMPA, which you heard in the chapter of contraception also. So DMPA 150 milligrams once in 3 months you can give, or you can give tablets of Dynogest. That is this new exciting drug which is now used. A lot of people don't like the injections given on a 3-monthly basis. You can give Dynogest. Both of these will cause atrophy of the endometrium. Can estrogen cause problem? We are coming to that, my friend. Yes, the whole chapter is about that. So hold your guns, listen to me. Okay. Momin Liaquat, welcome here. Speak in Hindi. Yadav, Priyanshu, look guys, I'm so sorry. The exam is going to come in English यार. तो मैं हिंदी बोल सकता हूँ, मैं चाहता हूँ कि आप हिंदी सुने, बट यहाँ पे बहुत सारे मेरे दोस्त साउथ के भी हैं, उनको फिर तमिल चाहिए होगी, किसी को बंगाली चाहिए होगी, तो कि আমি বাংলা বলুন কি আপনার কি কিনতে চান আপনি, how much do you want guys? So we have to speak in English guys, so that is the medium of instruction. ठीक है, कुछ समझ में नहीं आएगा तो पूछ लीजिए मुझसे, मैं हिंदी में जो पार्ट समझ में नहीं आया मैं हिंदी में एक्सप्लेन कर दूंगा, ठीक है? चले आगे बढ़ते हैं. तो डायनोजेस्ट प्रोजेस्टेरोन देने से एट्रोफी हो जाता है. और आगे बढ़ते हैं. अब हमें ईस्ट्रोजन, वी आर ट्राइंग टू रिड्यूस द ईस्ट्रोजन कम करना है. तो ईस्ट्रोजन कम करने के लिए, एंटी ईस्ट्रोजन एक्शन करने के लिए हमने बताया यू कैन रिड्यूस बाय OCPs, यू कैन रिड्यूस बाय द प्रोजेस्टेरोन्स, एंड यू कैन गिव एंड्रोजन्स. Androgens are anti-estrogenic, so they cause much faster atrophy. Androgen have an anti-estrogenic action, so that's why when you give danazole will be, it's a tablet which is having an androgenic action. It has got a high androgen action and it makes a low estrogen environment. It suppresses the GnRH and the gonadotropin secretion, so it does not allow the ovulation also to happen. Ovulation is the one which is making estrogen and progesterone, all right? And it directly inhibits steroidogenesis, so also causes increased clearance of estradiol and progesterone. So this mode of action of danazole keeps coming in your exams. How does danazole help? It basically is a anti-estrogen kind of action because it's an androgen. And how does this act? It reduces the androgenic environment by the suppression of the estrogen. It reduces the estrogenic action by increasing the androgenic action and also suppression of the steroidogenesis. Okay, but yes, androgens will have side effects. So you can give it for a year or so, maybe 2 years, but by the end of this first year, 1.5 years, she will have the side effects of hirsutism. And the hirsutism, you know, is the male type of baldness, facial hair and acne. But they can be worse. Hirsutism is male pattern baldness in a lady, facial hair, acne. But what is virilization? Virilization is hoarseness of voice. The voice of the girl starts sounding like a boy, hoarse voice, and breast atrophy and clitomegaly. Now, why did I make them separate headings? Guys, concentrate. Why did I make them separate headings? Because virilization is irreversible. Yes, virilization is irreversible. If you stop androgens, if you stop the androgens, then the patient will have reversal of the hirsutism. The acne will clear up. Okay, the acne will clear up. The facial coarseness will clear up. But if you stop the danazole, the virilization won't get treated. Virilization is lifelong. Yes, these are permanent. It is irreversible. That is what is the difference between hirsutism and virilization. So when there is virilization, you cannot reverse it. So that's why we always ask you, what are the indications of stopping the treatment by danazole? The first sign of stopping treatment by danazole is the hoarseness of voice, MCQ. That stop the treatment by danazole if the woman starts having hoarseness, because next she's going to have a clitomegaly. I've seen a girl with a clitomegaly. It was so bad, not because of this. I mean, she had some androgenic tumors. It was like a small penis in a lady, and it was a 2 centimeter long clitoris. So that's why clitomegaly can be an extremely worrisome condition for a lady. And if you stop the androgens, the clitomegaly does not shrink back. Yes, it will persist. The clitomegaly will persist for life. You will have to do surgical management. So that is why we must understand the difference between hirsutism and virilization. That's why we are impressing upon the outright basics which my students from PW should understand, right? So next, what we can give the GnRH analogues. Now GnRH analogues, before giving that, मैं समझाना चाहता हूं कि GnRH नॉर्मली क्यों कैसे काम करता है और GnRH एनालॉग्स क्या होते हैं। तो GnRH क्या होता है, ये एक पल्सेटाइल रिलीज है। आपको पता है कि एक पल्सेटाइल रिलीज होता है विच इज वंस इन 90 मिनट्स। और ये GnRH गोनाडोट्रोपिन रिलीजिंग हार्मोन पिट्यूटरी पे एक्ट करेगा और वो गोनाडोट्रोपिन्स को निकालेगा। गोनाडोट्रोपिन्स मतलब FSH एंड LH। तो गोनाडोट्रोपिन रिलीजिंग हार्मोन पिट्यूटरी, FSH, LH, ovary makes a follicle estrogen, ruptures the follicle, the same follicle becomes corpuscular, makes the progesterone. So estrogen and progesterone in the ovary because of the stimulation of the pituitary by the GnRH. ये हमारा normal menstrual cycle है। ये मैंने हमेशा बोला है, do not come to any hormonal chapter without reading the menstrual physiology chapter. That is the core of my classes. Once you understand those two chapters which are there, you've already been given the notes on the online sources. So please read the menstrual physiology chapter. That is extremely important. So once you understand that, now GnRH analogs क्या होता है? GnRH analogs. Analogs means drugs which are like GnRH. Drugs which are like GnRH. So like GnRH मतलब GnRH is stimulating the pituitary. Like GnRH will also stimulate the pituitary. Correct? Correct. Analogs are the same drugs like GnRH. They will also stimulate the pituitary. ध्यान दीजिए यहाँ पे, please do not get distracted. Any one of you thinking of anything else, if you not understood the chapter endometriosis, ठीक है. If you joined just now, understand GnRH analogs, especially my MBBS students. The interns and the post interns, PGs have understood this part. But my MBBS students are the major concentration for this class. And understand that GnRH analogs are the same as the native GnRH in the body. GnRH analogs, same action hai. So same action if you do the same action like the GnRH, the same action is the GnRH analogs. So don't you think you'll stimulate the pituitary too much? And the pituitary will make more FSH, and more FSH will make more ovarian follicles and more estrogen? Yes, GnRH analogs will do that only, correct? So we change the method of giving. Remember, the drug is given in a different manner. Normally, the GnRH is pulsatile once in 90 minutes, but we give continuous GnRH analogs. So when you give this GnRH analogs continuously in a continuous infusion or in a depot form, we give a high dose of GnRH analogs into the muscle of the lady, and it works for 1 month. Some injections work for 3 months. So continuously you give this in a daily inhalation form or an injection form or a depot form you give. Either way, you're constantly giving GnRH, not in a pulsatile form. देखो पिट्यूटरी को आदत होती है कि once in 90 minutes में उसे स्टिमुलेशन मिलता है, तो 90 minutes में एक बार वो काम करती है पिट्यूटरी. That is what is the basis about the pituitary function. 90 minutes में एक बार काम करना है मुझे. But now what do? You give it continuous stimulation. Stimulate, 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 and stimulate, stimulate, stimulate. आप उसको ब्रेक ही नहीं दे रहे हो पिट्यूटरी को. पिट्यूटरी बोलेगी भाड़ में जाओ, मैं काम ही नहीं करूंगी. Yes, पिट्यूटरी will say I will not work. You're stimulating me so much, I cannot work so much. I work once in 90 minutes. So yes, ये pituitary, you stimulate it so much that it cannot respond to the stimulus anymore. Pituitary थक जाती है काम करते करते. So when you give it so much of stimulation, it'll work. It'll try to work up to the stimulation for 1 day or 2 days, and then the pituitary gets suppressed. So yes, this causes something called down regulation. The word, all these receptors get down regulated. They cannot respond to the stimulation anymore. So yes, there is down regulation or desensitization, down regulation of pituitary. So pituitary is now sleeping. Pituitary is now sleeping, and that pituitary which is sleeping, that means there is no FSH and LH. That means the ovary is also sleeping. That means there is no estrogen and no progesterone. That means there is atrophy again. Yes, there is atrophy again. So we cause atrophy by this. Then we had caused atrophy by the androgens. They will also cause atrophy of the endometrium, faster atrophy. Then we discussed about the progesterone. They cause the atrophy. And then we discussed about the estrogens. Estrogens cause the limitation. They cause the limitation of the endometriosis. So, medical management, I am trying to be very repetitive here. Medical management aims at causing limitation of the endometriosis by OCPs, atrophy by progesterones, atrophy by androgens, and atrophy by GnRH analogues. What are the names of the GnRH analogues? Leuprolin, naferlin, gosserlin. There are many lins, okay, GnRH analogues. Yes, so all of these will cause the woman to have a good relief in endometriosis. This GnRH analogues is supposed to be the best medical management, best medical management of endometriosis. Okay, remember that. So yes, now the problem is, somebody is already asking me, if you suppress the estrogens for a long time, what will happen? So yes, I'm giving GnRH analogues. It's giving me very good results. The patient is fine. It has got atrophy of the endometrium, so she has no pain in the pelvic pain. There is no dyspareunia, and she's having much relief from the disease. But she's also not having periods because there's no estrogen. Okay, I'm saying this is for your treatment. As long as the drug is given, you will have no periods. Correct. But your disease also won't trouble you. So you have to live with that you're not having periods for some time. Okay, sir, you're healing me. Thank you so much. But if you do not give estrogens for more than 6 months, then the bones will miss the estrogens maximum. The bones will miss the estrogen very badly because estrogen is required for the bone formation. Yes, please see the HRT chapter. All right, the PW, all the app, we have given all these important chapters. Please see the HRT chapter. Estrogen is paramount for the woman. That estrogen is not there for this woman. If you stop the estrogen production for more than 6 months, it can cause osteoporosis. If given for more than 6 months, can cause osteoporosis. But that does not mean that I will stop my treatment. Very important fundamental here. I know if you give GnRH analogues for more than 6 months, it can cause osteoporosis. But I can continue the treatment with GnRH analogues and give her a little bit estrogen, which is required for the management, for prevention of the osteoporosis. So yes, after 6 months, look, there are many women we give GnRH analogues continuously, 3-4 years we've given. Excuse me. But after 6 months, we give some low dose estrogens to prevent the osteoporosis, and that is what is given by the add back therapy. That is what is known as the add back therapy. This is what is the pharmacology question which keeps coming. What is the meaning of add back therapy when you're giving GnRH analogues? So that estrogen reduction is good for the treatment of endometriosis, bad for the bones. It causes osteoporosis. So continue the GnRH, but give a low dose estrogens. So we can give this tibolone. Tibolone is a synthetic estrogen. HRT chapter, okay, please see that synthetic estrogen, and it has got a progesterone action. Norethistron can also help in the osteoporosis, and conjugate equine estrogens with medroxyprogesterone acetate. Okay, equine estrogens with medroxyprogesterone acetate. We can give these also. So this is what is known as the add back therapy. Continue giving those drugs, and one of these drugs, generally I give this tibolone, or I give a low dose of estrogen tablets. We have estrogen tablets like Primarin, low dose of Primarin I will add. Okay, so all these drugs will help the osteoporosis. That's about endometriosis. I actually got very emotional about this chapter because we see so many young girls. Which book? PW, the app of OBS and Gynae. Man, that is the app to read. All right, come on. Which so what about the other hormones which are secreted? So pituitary is not totally suppressed. Good question. I like that question so much, future doctor. The problem is when you give GnRH analogues, that is going to tire out the pituitary. Which part? The gonadotropin releasing hormone agonists, they are going to stimulate the pituitary's FSH and LH making parts. Those parts get they get so much down regulated, not the entire pituitary. Yes, You are not suppressing the entire pituitary. So pituitary is, it's the master gland. You know about that. So it is going to help in so many other functions. Only LHFSA production is reduced. Good question. Good. That means you're listening. Good. Chalo आगे बढ़ते हैं guys. If you don't have any other questions, which book you are referring to? Again, the PW app is the best book. Yes, you guys are here with me because you are doing the best kind of education with the best teachers. You're trying to understand the basics with us. Outright core basics. That's what we always teach you in our classes. All right. Chalo आगे बढ़ते हैं. To prevent osteoporosis, what is given? Once again, it's there. It's there. We're still in that same screen. Sudha, we are in the same screen still. Okay, let's move on, guys. And Sudha, you can see this. Let's get into fibroids. Okay, fibroids or leiomyoma. Here, yours truly, I'm holding a fibroid after a myomectomy. This is one of the 23 fibroids I took out in this patient. Long surgery. This was done during the Corona days. So, in addition to wearing a mask and then wearing a shield and then having another shield in front of me, there were some days, man, doing surgery during the Corona days. And there was no AC. It Corona started in the time of March, April, and it was peak heat summers, and the ACs were put off because the ducts are all connected. So in big hospitals, so if there is a Corona patient you're operating and the aerosols, it was assumed that all of that is going to take the virus all across the hospital. So that's how it was. Anyway, so let's see about fibroids. Now, fibroids, also known as leiomyoma. So when you talk about leiomyoma, you must understand it is the most common tumor of women. Yes, let me just stop this and give you the understanding. What is the most common cancer of women? You always say CA breast. Most common gynecological cancer of women, CA cervix. Correct. But that is cancers, malignancies. When I say tumors, tumors can be benign and malignant. If you see a woman, okay, one woman standing in front of you, the woman top to toe, there are so many bodily organs. They can all have benign tumors and malignant tumors. So, tumor, if I say head to toe, all organs included, the commonest tumor in a woman is the fibroid uterus. Okay, commonest tumor in the woman. Malignancy, CA breast, CA ovary, you know very well. Commonest tumor in a woman is a fibroid. 30% women in the world have fibroids. All right. So as many as 30% all women, and it is 2.5 times more likely to happen if a relative has fibroid, and this woman has 2.5 times more chance. It is associated with chromosomal abnormalities also, and it is seen more in nulliparous women. And again, it is increased estrogens that is associated with fibroids. So that's the quick revision of the etiology. It is also associated with increased growth factors like the transforming growth factor and the platelet derived growth factor, PDGF rather, platelet derived growth factor, epidermal growth factor, and the vascular endothelial growth factor, right? So fibroids are monoclonal tumors, and these are smooth cell tumors. You will see these whorls. Can you see, if you just concentrate on this part of the histopathology, can you see there are whorls, circular arrangement of spindle muscles, whorls of smooth muscle cells you see in fibroids, spindle shaped cells, eosinophilic cytoplasm, oval nuclei with a blunt end. The pathology teachers will tell you all of this much better, but I thought I'll just tell you that it's a monoclonal smooth muscle tumor, and these are surrounded by a pseudo capsule. So can you see this uterus, which is the normal muscle here? I'm trying to show you with shading. Now this is the whorls of smooth muscle cells, and this red line is there to show you that it is an encapsulated area here. It's an encapsulated area here. So we say it is an area of smooth muscles, whorl shaped arrangement of smooth muscle fibers. So you can see in the uterus, you will see an area of a fibroid. You can see it easily. Now, here I am going to take a break and make you understand a few more things. So, concentrate, guys. So, fibroid uterus, the fibroid may be like this, the fibroid may become bigger also like this. Again, in a whorl, circular arrangement, गोलाई में रहता है, whorls of tissue, गोलाई में रहने वाला ऐसे. तो फाइब्रॉइड ऐसे ऐसे भी बढ़ता जाएगा, ठीक है. So, fibroid will be a circular arrangement of smooth muscle fibers. So, fibroid is an irregular enlargement of the uterus. Irregular enlargement of the uterus most of the time. I'll show you many pictures also just now. irregular enlargement. But there is something called adenomyosis. Adenomyosis is different. Adenomyosis has uniform enlargement of uterus. Wait, I can show that to you immediately now so that we don't keep imagining things. Let's see if I have my. See this, guys. This is the regular enlargement of the uterus here. See, this is adenomyosis. Fibroids, I'll be showing a lot of pictures in this lecture. This is adenomyosis. Now, there are three things now we're discussing together. Okay, so don't get confused. Concentrate. No left, right. Okay, only center. इधर उधर की बातें नहीं करनी. When we're talking about endometriosis, blood going outside the uterus and getting deposited over the ovary, ectopic endometrium in the pouch of Douglas in the ovary. Sometimes the blood goes out from the uterine cavity here. See, this is the compressed cavity and it goes only into the muscle of the uterus. So there is blood which is ectopic again. यूट्रस से बाहर ग्लैंड चले गए. कहां गए? यूट्राइन मसल के अंदर. The glands have gone outside the uterine cavity. Now they are within the muscle of the uterus. That is what is known as the adenomyosis. If the glands go out and they are present in the pouch of Douglas, on the ovary, on the bowel, in the diaphragm, endometriosis. Glands go outside the uterus, are present in the muscle of the uterus, adenomyosis. Look, the adenomyosis uterus is uniformly enlarged. This is uniformly enlarged. Okay. And now we're talking about fibroids. Fibroids are nothing to do with ectopic endometrium. Fibroids are smooth muscle tumors. All right. So that is a different etiology. But I'm comparing all of these because you asked me in the beginning of the chapter the difference between that. And endometrial cancer will be in the uterine cavity. Okay. So that some of the time we'll discuss. So abhi I'll get out of this. Back to my lecture. Yes. क्या पूछ क्या रहे हो तुम लोग? मैं वहां पे चले जाता हूँ. All right, same things. Okay, Fahad, thank you. Okay, let's move on. Fibroids are monoclonal tumors, and I told you about this already. Yes, so there will be this irregular enlargement of the uterus in a fibroid. Okay, now let's move on and see what is the morphology of fibroids. A lot of questions are coming on this these days, especially for the NEET exam students. Okay, so what happens? Fibroids will always start in the muscle of the uterus. Basic. Fibroid शुरू कहाँ होता है? हमेशा uterus की muscle में शुरू होगा. So fibroids start in the muscle of the uterus, and that is treated as a foreign body by the uterus. There is a muscle, whirl of smooth muscle here. Now, suppose I'll try to show you with my hand here. Yes, I have a better example. I'll show you with this. Yeah, here. Look, the same thing I'm trying to show you with my hand here. See? Yeah, see, there's a fibroid here in this uterus. Can you see? Just that I'm reproducing here. Can you see this black dot? Yes, it is there. You can see. Now, this uterine muscle does not like this fibroid. Fibroid is treated as a foreign body by the uterus. The uterus goes on contracting. It goes on contracting to push this fibroid away from this uterine muscle. So the fibroid starts in the muscle, in the intramural area. Uterus tries to push it out. So this fibroid gets pushed outside and becomes subserosal. Sometimes it gets pushed inside and it becomes submucosal. That is what is the part of fibroid which is never understood. When we keep reading such big books, we don't understand the outright concept. The concept is fibroid will start here and move on. So it is treated as a foreign body by the uterus. So uterus responds by contracting on the fibroid to push it, and it can be pushed outwards and it can become a subserosal. See, this is a subserosal fibroid. Subserosal. Okay, it may get pushed outwards or it may get pushed inwards and may become a submucosal fibroid here. So subserosal, and this is submucosal fibroid. Okay, so this is what happens to the fibroid. And many other places in between. Concentrate, nothing else. Sit straight, no left, right, only center. Fibroid muscle में शुरू होता है. With the contraction, it can go outside, it can go inside. Inside is called submucosal, mucosa cavity में coming, it is known as mucosal. Then goes to the serosa surface, subserosal, and many other places in between. That is what is the classification of fibroids which is coming in your exams. So that is the basis of the classification of fibroids. So now I am showing you type 4 पे concentrate करेंगे हमेशा. Type 4 is the most common type, intramuscular fibroid. From there it can move towards the cavity. See, type 3, it is touching the cavity. It can come into the cavity, type 2. It is more in the cavity and less in the muscle, type 1. It is totally in the cavity. See, it is hanging in the cavity by a stalk, type 0. Or it may go outwards. From 4, it may go outwards. See, it has become, from 4 it has become a 5. That is going towards the serosa, but mostly in the muscle, somewhat in the serosa. Now it becomes a 6. It is very less in the muscle, mostly in the serosa. Type 7, only in the serosa and hanging. Hanging means pedunculated, something hanging. Look here, see, something hanging with a stalk. Let's say if you imagine this head as a ball, okay, so this is hanging, this is hanging. Suppose it is hanging like this. This is pedunculated, something is hanging. You have bulbs hanging with long metal poles, pedunculated. Our fans are hanging with those poles, pedunculated, okay, something hanging. So let us see this. So that is the basis of the FIGO classification. So we always start with the type 4. Once you see the type 4, intramuscular, okay, I'll stand on the side, okay. Type 4 is intramural here, within the muscle. Then it goes towards the cavity. So 100%, see the type 3, it is 100% intramural, but it is touching the cavity. Now, it is more than 50% in the muscle. Look at type 2, please. 50% in the muscle, but partly in the cavity. Now, type 1, less than 50% in the muscle, but rest is in the cavity. So, type 1 is less than 50%. So, type 2 is more than 50%, type 1 is less than 50%. And type 0, pedunculated, intracavity fibroid, hanging. Look, what I want you to consider here is that in all this nomenclature, I have said the intramural part first. I've always mentioned the intramural part first so that you don't have confusion in understanding. So it starts in the muscle and it is going towards the cavity, type 3, partly in the cavity, type 1, more in the cavity, type 2, and totally in partly in the cavity, type 2, more in the cavity, type 1, and totally in the cavity, type 0. So that is the classification. Now you have to see the other way. From 4 it becomes a 5. More than 50% in the muscle, but it is partly in the serosa. See, subserosal, type 5. Type 6, less than 50% in the muscle, but mostly in the serosa. See, 6. I showed you earlier also, now I have written this here. And type 7, subserosal, pedunculated, hanging. Now, these are the basics. Now, there is another type of fibroid which is found only in the cervix. So, that is what is a type 8 or the parasitic fibroid. Also, there is another one. So, type 8 which is in the cervix. A fibroid in the cervix is known as type 8. Okay. But type 8 is also a fibroid which is, let's say, which has detached and is somewhere else in the peritoneal cavity. So, there is a fibroid like type 7, it gets detached and now it is sitting in the pouch of Douglas. So, we say it is type 8, or it might be detached from there and it might be lodged under the diaphragm. That also becomes a type 8. So, cervical fibroid, here any fibroid of the cervix is type 8. Any fibroid of the cervix is type 8. There we don't say muscle mein jyada, muscle mein kam, all that doesn't come there. Any fibroid in the cervix is type 8. And fibroid which is in the pouch, which is away from the uterus, we say it is somewhere else. The fibroid was starting in the uterus, but now it is found in the pouch and it is growing there. It is formed in the diaphragm, it is formed in the omentum. That is what is known as the type 8 also. All right. So, type 2-5. Now, this came only once in the INICT, so I have to teach you that. Part of the fibroid is partly, see the 2-5. Part of the fibroid is coming into the cavity here, see? Yeah, but part of the fibroid is also coming to the serosa here. So, one fibroid has a cavity ka part and the same fibroid also has a serosa ka part. It has got two parts, this fibroid. this part, this side it is coming to the mucosa, that part it is going to the serosa also. That is what is a 2-5 fibroid. It's a hybrid. It has got two connotations. दो जगह से, मतलब एक जगह से वो म्यूकोसा में आ रहा है, दूसरी जगह से सीरोसा में भी जा रहा है. So that is a 2-5 hybrid fibroid. All right, so that is the FIGO classification. Now tell me, what is this fibroid? Yes, I have marked an arrow here, and tell me, what is this fibroid? This she's got many other fibroids here. She's got a tube and the ovary. See the altered tube over relation. Can you see this altered tube over relation here? And that's why infertility in fibroids also. But tell me, what is this fibroid, which is having a stalk here and a big fibroid which is small stalk on the surface? Yes, this is a type 7 fibroid, isn't it? That's a type 7 fibroid. And this, when there's a stalk, they can get twisted on their stalks. All right, what is this fibroid? See, I've cut open the uterus to show you the fibroids. This is a fibroid which is mostly in the muscle, and it is just touching the cavity. So I'll say it looks like a type 3. And here there's a fibroid here which is mostly in the muscle but partly in the cavity. So this looks like a type 2 fibroid. This here looks more like a type 50-50 type लग रहा है, type 6 लग रहा है मुझे अभी ये. So these are the types of fibroid you can be asked. This is a little borderline kind of case, but yes, they are fibroids. They will give you a section and ask you what type of fibroid it is. या फिर they'll not give you a picture, they'll just draw and ask you what type of fibroid is this. And this is a fibroid inside the cavity. This is a fibroid inside the cavity which is hanging. This is a hysteroscopic view. So can you see a nice round structure which is hanging? This is a pedunculated type 0 fibroid. What is this fibroid, guys? This is my favorite picture, one of the hysterectomy specimens. So you look at this and think that this is the fibroid. Some of you thought that. Don't lie to me. You thought that, isn't it? This is not the fibroid. This is the uterus. ये यहाँ पे tube है. This is the tube. This is the hysterectomy specimen. We've taken out the uterus, and this whole thing here is the fibroid. Look, this is the mouth of the cervix. You're seeing the opening of the cervix here, and the cervix is involved in the fibroid here. So any fibroid in the cervix is type 8. This is a type 8 fibroid. Okay, type 8 fibroid. It's got a very interesting name. लालटेन ऑन द डोम ऑफ सेंट पॉल्स कैथीड्रल. सेंट पॉल्स कैथीड्रल लंदन में एक चर्च है. चर्च के ऊपर एक लालटेन है. उस लालटेन के जैसा ये दिखता है. तो पहले हमें जनरल नॉलेज भी पता करनी पड़ेगी टू अंडरस्टैंड द appearance of this fibroid in the cervix. If you know, you have passed your exam. But it is called the Lalton on the dome of St. Paul's Cathedral. All right, that is what is the St. Paul's Cathedral here. ये जो यहाँ पे दिख रहा है ना, Lalton on the dome of St. Paul's Cathedral, वो वाली look है ये. Thanks to Google, I have also seen it. Of course, when I finally reached London and saw that, इतना बड़ा चर्च है, उसके ऊपर आपको दिखता भी नहीं है. कैसे उनको पता चला ये Lalton is like that? But हम लोग अपने बचपन से, मतलब right from my third year of MBBS, my professor has been, you know, all our professors have been telling about the cervical fibroids, Lalton on the dome of St. Paul's Cathedral. All right, so that is a very, you know, traditional gynecologists love to hear these things. Okay, चलो आगे करते हैं ये symptoms की बात. There is pain abdomen, dysmenorrhea, and compression because of fibroid of vital organs such as the ureter may also cause hydronephrosis. These fibroids can become very big, and torsion can happen. Fibroids can get turned. So this patient here, see the fibroid which I showed you earlier, this actually came to me with a torsion, severe pain abdomen. So we had to do emergency hysterectomy. She was an older woman, so we could do a hysterectomy. Anyway, there were so many fibroids in this patient. So this, see, this area can undergo a torsion. So that's what is one of the problems, but that is very rare. Huh? Torsion is not the commonest. Don't say torsion is the commonest. No. Pain abdomen, menorrhagia, and you know, dysmenorrhea, these are the major symptoms. All right. So what is the other problem with fibroids? The fibroids can have, apart from pain and increased bleeding, the fibroids can undergo a degeneration. These fibroids can undergo a degeneration. So these tissues, these extra tissues, when they get degenerated, there are multiple types of degeneration. So this becomes a short note in your exams. What are the types of degeneration you see in fibroids? So most common degeneration is the hyaline degeneration, and the rarest degeneration is the sarcomatous degeneration. I try to make you understand the core basics. So commonest is the hyaline, and the rarest is the malignant degeneration or the sarcomatous degeneration, which is, they've asked you less than 1% cases, you see this. All right. Then there is the calcific degeneration. They can be, that is a womb stone, cystic degeneration, fluid type of collection, lipoid degeneration, fatty collection, necrotic or infectious degeneration. But most common is hyaline and rarest is sarcomatous. But there's another degeneration which I have not even mentioned here. That is the red degeneration, and red degeneration seen in the pregnancy. So that's why I have given you another slide for that, a more dedicated part for this red degeneration. So most common in pregnancy is the red degeneration. This is the solid MCQ. Red degeneration seen in pregnancy, and this starts in the second trimester, and it presents with pain abdomen and uterine tenderness and fever. The treatment is conservative. Purple, red due to thrombosis of the veins, all right, more description. Conservative management, that is painkiller de do, उसे sedation de do, आराम करा दो. She is pregnant and having a fibroid. So याद रखो, the biggest problem with fibroid surgery, is that a fibroid surgery will bleed a lot, even in a non-pregnant woman. Biggest problem. The chapter now will turn towards that. कि fibroid में bleeding कैसे कम करनी है. That's the only discussion after this introduction. So now the woman is pregnant. In addition to having a fibroid, she is pregnant. She's got this pregnancy. Now, when there is pregnancy, along with that, there is a fibroid. This is an extremely vascular time, extremely vascular surgery. It will be, I mean, the area will be so vascular that if you make an incision on a pregnant uterus, I don't know, some of you are interns if you're watching this, and those final year students who have seen cesarean sections. Any cesarean bleeds a lot. So that's why we do a lower segment cesarean, and the resident is busy making sure that the lower segment doesn't bleed. If that uterus can bleed so much, suppose you're trying to do a fibroid removal in a pregnant uterus, that can bleed like crazy. So bleeding in fibroids is a major problem, and fibroids bleeding in pregnancy is still bigger. So no surgery, conservative management, painkillers and rest and sedation. So NSAIDs we give her in pregnancy, we give her sedation and we give her rest, but we give no surgery, okay? No surgery of fibroid in pregnancy. Remember that basic, all right? Chalo. Now this is a menorrhagia as the most common symptom. I'm trying to show you what is the cause of bleeding in fibroids. Now this is where they want to ask you a lot of questions. So let me try and show you with this example, simple example here. Look here. Why do fibroids bleed so much? What is the most common presentation of a fibroid? Excessive bleeding. Don't forget that. Pain bata diya, dysmenorrhea bata diya, degeneration bata diya, and compression of other organs I told you. But overall, the core understanding, fibroids bleed a lot. Menorrhagia is the most common presentation, excessive bleeding. What is the mechanism of excessive bleeding? So normally, you know, when the uterus, okay, there is a fibroid here. I'll show you with a normal uterus here. This is a normal uterus, and in this normal uterus, you're seeing that the lining will shed every month, and the base of the uterine muscle, the glands here, these glands, when they shed, the base of the glands, the blood vessels are going through the muscle of the uterus. Those glands, when they shed, the base of those glands will bleed. That's why when shedding happens, glands will come out and blood also comes out. So lot of women will have bleeding in periods, and that bleeding is 5 days, 3 days, 4 days normal. So to reduce the bleeding, what does the uterus do? All these blood vessels which are bleeding, the uterus undergoes a contraction. Uterus contracts to stop the bleeding. That's a normal mechanism for any woman who is having menstruation. But what happens when there is a fibroid in the uterus? Look, I'm making a uterus with a big fibroid now. Can you see this? There's a uterus with such a big fibroid. So now she sheds the endometrium, she has bleeding little bit, but the uterus is not able to close totally. See, it is not able to contract and close totally. So uterus is contracting, it is trying to close, but the fibroid is acting like a foreign body and not allowing the uterus to totally contract. So uterus wants to contract and stop the bleeding, but the fibroid is in the way. So this is the reason why the uterus cannot contract completely. Ineffective contractions. So contractions stop the bleeding. Remember, in PPH also we say contractions stop the bleeding. In a normal uterus also, uterus closes the blood vessels by contraction. That is not able to happen because of this foreign body. So that is one reason. Number two, the glands of the uterus, they are formed over the lining here, they are formed over the lining here, but they are also formed all over the fibroid, below the fibroid and behind the fibroid. All over the glands will be formed. So number of glands is more in a case of fibroids uterus. All right. So this is what you have to understand. So increased endometrial surface, ineffective contractions, and increased congestion because of increased vasodilator prostaglandins. These three things are the reason why there is more bleeding. Remember these causes, guys. Also, there are other patterns like there is progressive menorrhagia, that is more with the intramural and submucosal fibroids, and menometorrhagia due to submucosal fibroids. These are the patterns. So, menorrhagia, progressive menorrhagia, and menometorrhagia. These are the fancy names which are associated, but basically you have to say menorrhagia. If you say that part, you have passed your MBBS exam and you passed your entrance exams. If that you know, I'm happy. These are the other fancy terms. Yes, it is progressive menorrhagia, that the menorrhagia goes on increasing. Next month she'll have more, and the month after she'll have still more bleeding. And menometorrhagia means irregular acyclic bleeding. So because of submucosal fibroids. Infertility because of the altered tube-ovarian relations, which I told you already, but in addition to that, increased uterine contraction will not allow the embryo to implant. That is simple. Associated PID and endometriosis can happen, distortion of the cavity can happen because of the fibroids, and then blocked tubes, especially at the cornua, and also due to the stretching of the tubes. The tubes which are so badly stretched, I showed you a couple of pictures. The tube which are so badly stretched, those stretched tubes will obviously get blocked, and also because of the compression by the fibroids, the tubes can get blocked. And bowel and bladder symptoms can happen. You see this fibroid at the top. I'm trying to show you a woman like this, like the way I'm standing. I'm trying to show you a woman from the front to the back. So you can see the pubic symphysis. This is the anterior part of the lady, and then this is the bladder, this is the uterus. Now there is a fibroid on the uterus. It is pressing on the bladder, so it will cause her to have more frequency. First there will be hesitancy, then with the fibroid increasing size, there will be more compression on the bladder, there will be more frequency. Then eventually the fibroid becomes very big, there could be retention of urine. Now retention of urine is more because the posterior, see, posterior cervical fibroid. This posterior cervical fibroid, it becomes so big. See this? Look at my hand and look at this cap, which I'm trying to show as a posterior cervical fibroid. So this posterior cervical fibroid will press the uterus forward. See, it will press the uterus forwards. It will press the uterus forwards, and that will compress the urethra, and that compression will cause retention of urine also. So yes, posterior fibroids can cause constipation, they can cause retention of urine. So initially there is increased frequency, hesitation, and then there can be urinary retention by the posterior cervical fibroid, like I told you. All right. So diagnosis can be done by ultrasound, but the best diagnosis of the fibroid is done by the MRI, fibroid mapping, where the fibroids are present. That is best done by the MRI. Okay. Before we say that I have to do a myomectomy, I have to take out the fibroid of this lady, make sure that you assess the endometrium also. A lot of times the fibroid might be just present in the body and not doing much, but she may be having an endometrial hyperplasia. That could be the cause of bleeding. So always rule out other causes of bleeding. Apart from the obvious cause, rule out the other causes. So rule out an endometrial hyperplasia. So before you do the major surgery of the fibroid, always look into the endometrium, the lining of the uterus. That one biopsy should be taken to make sure there is no hyperplasia or, God forbid, a cancer of the endometrium. Right. So what are the principles of treatment of fibroids? So before I rush into that, because we are revising our understanding of fibroids, but now what are your questions before I go into that? Menorrhagia is more than 80 ml of bleed, and can it cause cancers? Yes, I told you. Yes, Sudha, I told you that it can have a malignant degeneration. Yes, so that is what is a cancer. Malignant degeneration is what is a cancer. Can cause, not so common. Rarest hai, less than 1%. I told you that, right? Why no surgeries? Pregnancy fibroid? Please repeat. Because a lot of bleeding. Uterus is a very congested uterus, lot of blood in the uterus. So if you do a cesarean also, that muscle bleeds so much during a cesarean. So a fibroid in pregnancy, if you operate, she can bleed to her death. That's why we don't do. All right. Infertility because of the all the parts you want again. I think you can revise by doing a rewind and play. But I can help you quickly. Infertility because of the altering tube ovarian relation. The tube gets here and the ovulation is here. Right from the beginning of the chapter, I'm telling you, altered tube ovarian relation, and reduced implantation because the uterus is contracting. It will push the embryo out when the embryo comes for implantation. So that is one thing. alter tube relation, then reduce implantation because of the uterus pushing out the embryo, and also because of blocked tubes. It's there, you can revise once more. And bowel and bladder because of the shear compression by the fibroids. Okay, so what are the principles of treatment? What are the mechanisms of treatment, that is methods of treatment, that is you can do a myomectomy or you can do medical management, all of that we'll discuss. But whom will you treat and whom will you not treat? That is also one question which keeps coming in the exam. This is the only question which came in the INICET and the MCA exam 1 year. Only question was which will you treat and which you will not treat. What is the treatment, most of you know, but which one requires a treatment, which one doesn't require treatment. So that's why we have made this kind of table is not there in any of your theory books, but this is what is accepted protocols across most of the practicing surgeons, right? More or less these are the accepted protocols. So if there's a small fibroid and there are no symptoms, there is no pain, no bleeding and no infertility, three main symptoms of fibroids. Most common is pain, most common is bleeding, but pain and infertility also are the symptoms. No PBI, no pain, no bleeding, no infertility, no symptoms are there, because the fibroid is a very small fibroid and it is, let's say, somewhere here. One chota sa subserosal fibroid is there, only 2 centimeters, and it is just like 30% women have fibroids. Not everybody will have any symptoms. So it is like a small mole on the face. Sometimes we have a mole on the arm. We don't know anything about it, isn't it? So that is a small fibroid. It is doing nothing. No pain, no bleeding, no infertility, no treatment required. No treatment required. All right. Small means less than 5 centimeters in size. Now, small fibroid less than 5 centimeters, but patient has pain, bleeding or infertility. One of these symptoms are there. Because the fibroid is here, it is again 2 centimeters only, but it is, let's say, a submucosal fibroid. A fibroid which is in the cavity like this will have more endometrial glands growing, will have a menorrhagia, will also interfere in the contraction, will have menorrhagia, will have a lot of pain also. So, pain and bleeding will be there, and this fibroid will also cause infertility. So, any of these symptoms will be the reason I'll have to do treatment even for a small fibroid. Treatment is required. Then, large fibroid more than 10 centimeters. Suppose the fibroid is as big as 10 centimeters and has pain, bleeding, infertility. Obviously, treatment will be required. What is the treatment? We'll see. I'll tell you. Depends on the age, family, that is number of children, all that. We are discussing that next. But treatment karna hai ki nahi karna? We are just staying there. All right. Then, large fibroids more than 10 centimeters, but has no pain, no bleeding and no infertility. Now, this is the MCQ which has come in the exams. Large fibroid which is asymptomatic. Please remember, this is an MCQ. Large fibroid which is asymptomatic. What do you do? Think. It's a large fibroid. She is, let's say, 51 years. She's had menopause, no periods. She's not having menorrhagia. And menopause, there is no chance of her saying I'm infertile, because she's already in menopause. She already has the children which she wants to have. There is no pain, there is no bleeding, definitely there is no infertility. She is 51 years. She came to me for a health checkup. Sir, I am 51 and my family wanted me to come for a health checkup because I got into menopause. So, mera full body checkup kar lo. I do a full body checkup and I do the investigation and all. Well, any doctor can write all those basic health checkup kind of things. And I do a general physical examination. Blood pressure and CVSRS, pulse rate and anemia, breast, thyroid, everything. Then I am doing a per abdominal examination. I see, you have a big tumor in your tummy. I do the ultrasound and see it's a 12 centimeter fibroid she has. Sir, mujhe to kuch problem hi nahi. I don't have any pain, nothing. I don't know that I have a fibroid. Totally asymptomatic. What do you do for that fibroid, guys? Come on, tell me. That was your question. So, yes. What do you do? So, yes, this is that one question. Large fibroid without any symptoms is still a reason for you to treat it. It is still a reason for you to treat it because it is asymptomatic now, but it is large, and large fibroids can have all those degenerations which I told you. They can have degenerations, they can have a torsion, and they can have also malignant transformation. Malignant degeneration can happen. Like Sutta was asking me, can cancer happen? Although it is rare, but it can happen. So large fibroids cannot be left alone. Treatment is required. Again, treatment is required. So there is only one fibroid where no treatment is required, and that one is the small asymptomatic fibroid. Small with symptoms, large with symptoms, and large without symptoms. All these fibroids will do the treatment. All right, guys. So yes, try and understand this. Extremely important. All right. Okay, so now we'll get into what are the methods of treatment. Before that, what are you asking me? More than 80 infertility, please. Okay, all that we discuss. The blood solid small fibroid less than 5, so will it fall off? Can it grow in future? Yes, it depends on the location, future doctor. It depends. If it is in the muscle, if it is a 5 centimeter fibroid, kitna likha tumne? 5 centimeter. If it is a 5 centimeter fibroid here, this will grow. It will become very big. यही तो है. पहले 1 होता है, फिर 5 होता है, फिर 15 भी हो सकता है. But if it is here, who knows? It may just degenerate and it may fall off. Correct. If it is here in the mucosa, she will not quietly go off from the OPD. She'll have a lot of symptoms. So depending on the location, the fibroids may become bigger. Correct. They can become bigger or they can shrink also. If they are subserosal, the blood supply may actually reduce. But if they are subserosal, they can undergo torsion and come with acute emergencies. So fibroid, every fibroid is open. You know, the number of fibroids I've removed in my life, and touch wood, all of them have gone home well, and I keep thanking the Almighty. But every time I open a fibroid, like while I'm teaching you today, yes, 24th of January 2026, next week I have a major fibroid removal in my hospital, and I'm already on the back of my mind, I'm thinking, सब कुछ ठीक हो जाए उसके साथ. And I'm pretty senior now. And even I may try to act very confident, but अंदर से मुझे भी डर अभी भी लगता है. There's a famous ad, no? डर सबको लगता है, अभी भी डर लगता है, because fibroid can bleed like crazy. सबसे बड़ी प्रॉब्लम है फाइब्रॉइड में. So we always hope that our experience helps the patient and she has a favorable result at the end of the surgery, and we are able to give her the best results, because a lot of time we have to remove only the fibroid and save the uterus. A lot of time you have to take out a big uterus away because it's a big fibroid. You have to do a hysterectomy. Anytime this fibroid surgery can bleed a lot. So yes, treatment is required, and it is only one place where treatment is not required, which is a small asymptomatic fibroid. Majavir Singh, what did you ask me? Oh, can you do this in Pakistan? I'm sure we can do this in Pakistan. Why not? I think you'll have to, I'm sure somebody is reading this. My team is reading this, and they will get back to you. Why don't you just send a hi to me? My number is there all over. A lot of your Pakistani friends have my number, man. All of the groups where I am. So you can just send me a message and I'll send it forward. Anyway, I'll ask okay, I'll do that. I'll ask my team to get in touch with you through this. You can just write. Okay. So let's move on and see the other things. Principles of treatment, large fibroid, all this I've written, all of that I've written. Large fibroid, if it is asymptomatic, what I told you, it can require treatment. So it is all mentioned here as notes. So let's, yes. So to save time, I wrote some notes for you already. So medical management of fibroids, surgical management and medical management. Medical management aims at reducing the bleeding and reducing the size of the fibroid, and also reducing the bleeding during surgery. So reduce pain and bleeding, you can give tranexamic acid. GnRH in logs is the best medical management. It causes downregulation of the pituitary. Same, I told you in the beginning of the class today. If you start today's Farre chapter, the first thing I said, estrogens are the cause of fibroids and of endometriosis. So basic treatment is reduce the estrogen. That's the first line I said when I started today's chapter. Okay, so we can reduce the congestion of the uterus and the bleeding by GnRH and logs, again by downregulation of the pituitary. All of that I've given you. So reduce the menstruation, that is the medical management aim. The aim of medical management, reduce the menstrual bleeding, reduce the size of fibroids, reduce congestion and intraoperative bleeding. All right. And tranexamic acid will cause the menstrual bleeding to reduce. Okay. So that's what is the. Now, apart from GnRH analogues, we also have something called the GnRH antagonists. GnRH analogs work on a principle कि pituitary को इतना stimulate कर दो कि pituitary थक जाए. Go on stimulating the pituitary, pituitary gets tired and pituitary doesn't work. So pituitary is not working. We have happy results. GnRH antagonists भी हैं. They will directly inhibit the pituitary action by antagonizing the GnRH action. So there's a GnRH antagonist also can be used to suppress the pituitary. Then we can use mifepristone. It's an anti-progestin. It has an anti-growth action. All right, and mifepristone also can be given. Ulipristal estate, selective progesterone receptor modulator. It's a pure antagonist action, and that also is given for fibroid management. I'm just quickly running down the medical management, and we can use Mirena, intrauterine progesterone devices, that IUCD, Mirena. What is basically Mirena? It is progesterone. So what happens? This progesterone in the IUCD, this will act on the endometrium, and you know that high dose progesterone will cause atrophy. High dose progesterone will cause atrophy of the endometrium. So endometrium gets atrophied. Although there's a fibroid here, but the endometrium, this endometrium gets totally atrophied. So yes, fibroid cause increase in bleeding from the endometrium. That endometrium have caused it to become atrophic by the IUCD having progesterones. So you can give progesterones to eat, they can cause atrophy, which I told you earlier in the discussion with endometriosis. Now I am telling you the same progesterones in the uterus we can give by IUCDs, the impregnated with progesterones, and they can cause atrophy. So I told you atrophy is the new word which I introduced in your lexicon this evening. We have introduced a new word, एक नया word सिखाया था मैंने आपको, atrophy. एंडोमेट्रियम की एट्रोफी करके हमें फाइब्रॉइड्स और एंडोमेट्रियोसिस दोनों में मदद मिलेगी. शुरू में मैंने बता दिया कि फाइब्रॉइड्स एंडोमेट्रियोसिस इज बिकॉज ऑफ हाई ईस्ट्रोजन. दोनों को ट्रीटमेंट कैसे करते हैं? रिड्यूस द ईस्ट्रोजन. दैट्स व्हाई ये दोनों चैप्टर्स हमने साथ में पढ़ाए आपको. ये आपको याद होना चाहिए था. व्हाट इज द मोस्ट इफेक्टिव ड्रग? आई टोल्ड यू ऑलरेडी द बेस्ट मेडिकल मैनेजमेंट of fibroid is GnRH analogs. That's what I showed you in the previous screen. New methods is uterine artery embolization, preferably after 35 years. You can embolize the uterine artery, so the blood supply to this uterus will reduce, and to the blood supply to the fibroids will reduce. Medical management you can do. And menorrhagia also will be reduced by this. Then surgical management. So medical management is what I told you. It is to prepare the woman sometimes for the surgical management also. So hysterectomy can be done for the surgical management of a fibroid. Hysterectomy can be done generally when women have completed family. So mostly we keep it for women after 40 years. Women after 40 years generally, and those who have completed their family. All right. Now younger women, myomectomy will do. So myomectomy, that is removal only of the fibroid, removal of fibroid only. That is what is a myomectomy. Now when we are trying to remove the fibroid, that myomectomy can be an extremely bloody surgery, can bleed a lot. All right. Now that removal can be done by open surgery, open the abdomen, do it, or can be done by laparoscopy. So सबके अलग-अलग criteria हैं. Gross criteria I'll tell you. So laparotomy can be done for all sizes. Laparotomy can be done for all sizes, all fibroids, all sides. पेट काट के तो कोई भी फाइब्रॉइड कहीं पे भी हम निकाल सकते हैं. Laparotomy. All right. Now laparoscopic is, can you see now? If I put a laparoscope in the abdomen, see the laparoscope will go like this, and this is the uterus. When I put a laparoscope like this, or I'll show you on my something like this. See this? This is the uterus. Okay, my hand is the uterus, and I'm putting a laparoscope like this. Okay, you can't see the laparoscope. Okay, this is the laparoscope. This pen is the laparoscope. So I put a laparoscope like this, and with the laparoscopy, which fibroid I can take out easily? Obviously, the fibroid which is on the surface will be easily accessible rather than the fibroid which is inside the cavity, isn't it? So with the laparoscope, I can take out a type 6, type 7, maybe even a type 5, but that requires more skill. So laparoscopic removal of fibroids, you should try only if you've done a lot of open surgeries. I have repeatedly said in this topic, the only problem I'm worried about in fibroid is the bleeding during surgery. So pregnancy में तो सर्जरी करनी नहीं है. ग्रॉस प्रिंसिपल बता दिया. अब आपका प्रोफेसर बोलेगा यार मैं तो कर सकता हूं. योर प्रोफेसर इज अ गुड प्रोफेसर. Rarely extremely smart surgeons can do. I'm not discussing here that how many fibroids are removed during the during the pregnancy. This is not the forum. Fibroid in pregnancy don't touch. एक basic principle है. हमें core basics padna hai. Exceptions in post graduation we'll teach. Okay, so fibroid in pregnancy don't touch. Fibroids can bleed a lot, and when fibroids bleed a lot, you have to be smart in the surgery. So laparotomy, any tumor, any fibroid, any size we can take out. Laparoscopy, it's better that we take out for type 7 and type 6, maybe type 5, but I'm not writing. Now hysteroscopic, go into the uterus. See, I'm going into the uterus with a hysteroscope. Which one I can take out? Hysteroscopically with a scope inside. So I can take out a type 0, I can take out a type 1, maybe a type 2, but again surgical skill has to be better. So hysteroscopic for type 0, type 1. These are the outright core basics. And before doing a myomectomy, you should have some understanding that the hemoglobin should be built up. You can make the woman amenorrheic. Uska periods band kar do, GnRH de do. Stop her periods so that she regains her hemoglobin. Give her iron ferrous sulfate capsules. You may give her blood transfusion, but if you can stop the bleeding and plan the surgery, that's always better. So many times we stop the periods of the lady, build a hemoglobin up, and then only do the surgery, because if the hemoglobin is less than 10, then the healing of the tissue is also going to be difficult after the surgery. So HP should be more than 10. Rule out other cause of infertility. Who knows, if you're doing a myomectomy, the cause of myomectomy could be that the man is having azoospermia. आपको लगता है कि एक बड़ा सा फाइब्रॉइड था 6 centimeters का, and that fibroid is the cause of infertility. You're planning a myomectomy. But actually the fibroid was a subserosal fibroid, and it was somewhere here, let's say 6 centimeters, and the tubes are away from this fibroid and the cavity is away from the fibroid. So this, even if it is 6-7 centimeters, it is not troubling the tubes, it is not troubling the cavity. आपने उसकी surgery कर दी, so myomectomy कर दी, it's a bloody surgery, it's a risky surgery. I've been scaring you about the myomectomy. फाइब्रॉइड निकालने में ब्लीडिंग हो जाता है, बट द पेशेंट कम्स टू मी आफ्टर 1 year एंड सेज, सर मेरा तो प्रेगनेंसी हुआ ही नहीं, आपने तो सर्जरी कर दी, आई एम नॉट प्रेग्नेंट स्टिल. एंड देन यू फाइंड आउट विद द सीमेन एनालिसिस ऑफ द हस्बैंड दैट ही इज एजोस्पर्मिक. ही इज एजोस्पर्मिक. अरे यार, ये तो बड़ी मुसीबत हो गई. व्हाई डिड यू डू अ सर्जरी फॉर दिस लेडी व्हेन द मैन इज एजोस्पर्मिक? दिस इज अ प्रीरिक्विजिट दैट hemoglobin should be more than 10, and you should have done a semen analysis of the husband before doing a myomectomy, because that myomectomy was a dangerous surgery and the woman could have died in the surgery. Yes, this has happened. Many doctors, it has happened that patients have lost their lives during a myomectomy. So please do this major surgery only if the semen analysis is fine. Okay, then during the surgery, minimal fimbrial and tubal handling, नहीं तो adhesions बढ़ जाते हैं. Minimal incisions on the uterus, and avoid posterior wall incisions, because it can cause fixed retroversion, which causes infertility. This we've discussed in the chapter of infertility in our app also, and fixed retroversion can be a problem. The retroversion uterus, I can explain you again like this. So when the woman is having intercourse, the sperms are deposited. Suppose this pen is the penis and the sperms are deposited in the posterior wall of the vagina. The cervix is downwards and forwards like this. So cervix is picking up the sperms after intercourse, but that is when the uterus is straight like this, anteverted, straight like this. But if the uterus gets retroverted, if it gets retroverted, the cervix will miss the pool of semen, and that's why the patient will not get pregnant after intercourse, because of a fixed retroversion. So that fixed retroversion can happen more if you do a posterior wall incision. If you do a posterior wall incision for the fibroids, it causes fixed retroversion. थोड़ा सा PG वाला हो गया ये वाला segment, but never mind, since I have to teach you to become the best postgraduates, you can learn a little bit more, right? चलो आगे बढ़ते हैं. And avoid opening the cavity. You know, sometimes we do end up opening the cavity, but cavity injuries can cause fibrosis of the cavity and more problems in pregnancy later. Now, techniques of reducing blood loss during the myomectomy, we have this myoma clamp. This myoma clamp, if you see this tip, these two prongs which are here like this, these, can you see aisa hai na? These myoma prongs, they are like this myomectomy clamps. So kya hota hai, there's a big fibroid here. So we open the abdomen and put this clamp next to the uterus like this. ऐसे clamp लगा देते हैं. So when you put this clamp, the uterine artery is compressed on both the sides. When I'm operating on this, the bleeding will be much lesser. And then, very important, vasopressin injections. So all of that is coming now. The methods to reduce bleeding. ये सब आएगा exam में. Yes, viva में आएगा. They'll give you a specimen in the evening viva with the fibroid in front of you, and they'll say, how do you reduce bleeding during surgery? Steps of reducing bleeding during surgery. So myoma clamp, and that is during surgery, but before the surgery you can give GnRH therapy to reduce the congestion and time the surgery in post menstrual phase of the menstrual cycle. Suppose she had periods on 1st of February and she finishes periods on 4th of February, for example. I'll try to do the surgery between 6th to 16th of February. That's the time, because after ovulation, then the congestion of the uterus increases and bleeding during surgery will increase. So generally post-menstrual rather than pre-menstrual. Okay, arrange blood and FFP. You must always do intrauterine use of a uterine clamp, this myomectomy clamp. Tourniquet, instead of a clamp, we can put a a plastic tube around the uterine arteries. We can do that also. And vasopressin, local vasospasm you can cause by vasopressin. This is not enough, writing this. I'll show you how we give it. That's what is very important, vasopressin injection. So yes, look here. This is a patient. Wait, I'll have to. Yes, look at this one. I've taken the uterus out of the abdomen, and can you see the size of the uterus is so big? Now I'm injecting vasopressin. Look at this picture and look at this one. Can you see? When you inject the vasopressin, before that it was also red and congested and it was going to bleed a lot. After injecting the vasopressin, can you see it's become all blanched and white? So this is how you're putting the vasopressin here. Always withdraw when you're injecting any drug into any place. Always withdraw any part where you're giving an injection. Always withdraw. If you give vasopressin into the circulation, sudden hypertension can happen. So when you're injecting this vasopressin, we tell the anesthetist, injecting vasopressin. Anesthetists kai bar busy hote hain phone pay, because anesthesia life. They are very busy in the OT, but they are also having the time to go and have tea in between and catch up on the gossip with their friends. I envy the anesthetist sometimes. All right. वो मेरे को जवाब देते तो नहीं लेना था ना गायनी, क्यों कर रहा है सर्जरी, एनेस्थीसिया करना था. Okay, that war we will discuss when you come to PG life. We'll discuss all that, all the war which goes on between anesthetists and the surgeons. तो ये देखिए, ये this is got totally blanched. देख रहे हो, you give the vasopressin, ये पूरा area देखो white हो गया. Now moment I make incision, hardly any blood loss is there. This is not much, please don't get scared. When you make an incision on the uterus, फुहारे छूटते हैं कई बार. You will have spurts going up till the ceiling of the OT and will come into your eyes so many times. So see, I'm able to do the surgery aram se without any massive blood loss. One, I've given the vasopressin and I put a tourniquet around the uterus, uterine arteries, and then I've given her GnRH analogues before, for 3 months before she came for the surgery, all to make sure that I will take out the fibroid and not take out the uterus when I want to do a myomectomy. So that's what, these are the steps. Chalo. Now the same surgery is still continuing. Then can you see now? This is a big fibroid, it's almost like this with this head of the baby, like this. I've tried to, yes, see here, I've tried to open the uterus like this. Like this, I'm opening up the uterus and taking out the fibroid here. Yeah. See this one now. Wait. Yeah, see this? Now, what is this instrument? I wanted to show you this instrument. This is your instrument. Yes, instrument question. All you exam going students for final MBBS and the PG students, entrance students. This Myoma Screw. This is what is screwed. This is like a corkscrew. That wine opener होता है ना, corkscrew. बिल्कुल उसके जैसा होता है ये Myoma Screw. It is put into the uterus and gives us traction while I'm trying to do the myomectomy. See, I'm giving a traction to the fibroid because of this. And then we're about to just finish this here. The base, now this is where, this is the part, the base of the fibroid when I'm finally trying to take it out. That base of the fibroid, uske niche hi to cavity hoti uterus ki. That cavity should not be injured. Try to, I mean, if you injure the cavity, of course, you will repair it also. It happens. I have opened the cavity many times. It's not that, we have always doing only good things. Yes, we end up in a few complications. But yes, again, touch wood, all the patients go fine and they have good results. Then any surgeon will have complications, but you should know how to diagnose and treat the complications. That's what makes you a good surgeon. Complication होता ही नहीं है, ऐसा कोई surgeon नहीं दुनिया में, कोई surgeon नहीं. All right, चलो, let's move on and see. This is the base of the fibroid which I've taken out, and now you have to close this in layers. And the surface, we say baseball sutures on the surface of the spirosa. right? So this is the number of fibroids I took out. This is just for the size. See, this is more than 10 centimeters. This one big fibroid is around 12 centimeters. So many fibroids in this patient. After the surgery, we generally like to, take a picture, show off. होता है ये, सब लोग थोड़ा पिक्चर लेते हैं ऐसा मेजर सर्जरी के बाद. This is a Myoma Screw. This is a hysteroscopic myomectomy. Yes, I was trying to show you कि hysteroscopic myomectomy करते हैं. तो hysteroscopic myomectomy also you should be, we use some media to distend the uterus. I'll not go into much detail about this surgery now, but this can also bleed a lot. So you should have done a lot of open surgery before you do laparoscopic myomectomy and hysteroscopic myomectomy. So this is the hysteroscopic myomectomy. This is a type 1 fibroid I told you ना. Type 1 fibroid होता है. इसमें it is mostly in the cavity, but some part is in the muscle. More than 50%, less than 50% in the muscle, and mostly in the cavity. So this type 1, I'm going the base of the fibroid to remove this. This is a bipolar cautery which I have. So with that, we try to take out the, yes, we remove this. And then this fibroid has to be taken out. This is almost 3 centimeters, this fibroid. So to take it out from the uterus, that is also another task. Okay, remove तो हो जाता है, but how do you take it out? That is also one nuisance. So this is that fibroid. Can you see? ये fibroid ऐसे घूमता रहता है. It keeps running. Can you see? ये internal os है और उस पे fibroid यहाँ पे आके फंस जाता है. So then, can you see that? Yes. Then you have to take it out also. But yeah, once you become a gynecologist, then we'll teach you all these small intricate details. Thank you guys. A lot of things we discussed, much more than what I was hoping that we will do today. But it's always interesting to take a class, and I'm happy that we do all of this. Now, what is Sudha asking me? Why laparoscopic done in time? I'm saying laparoscopy is done for anybody. Yaar. See, if somebody has a gallstone, don't you do a cholecystectomy with the open procedure? But we can do laparoscopic also, so that there is lesser incision, lesser size of incision, and laparoscopy the patient will recover very fast. Isn't it? Laparoscopy karke patient recovers very fast. Today you do the surgery, tomorrow the person goes home. But you cut the abdomen and do the cholecystectomy, he has to be admitted. Similarly, when you do a myomectomy, open myomectomy, the patient will be in the hospital for 1 week. But you do a laparoscopic myomectomy, she goes home. So laparoscopy surgery is a smarter surgery, more cosmetic. Okay, smarter surgery, and the patient recovery time is much lesser. Yes, pros and cons hain, but much lesser. So why do laparoscopy for 6 and 7? Easy to do. That's why 6 and 7. 4 and 5, they'll be difficult to do. Yeah, what is the possible getting pregnant at age 46? What is possible? Is it possible at 46 years? Yes, it is possible. But 46 years, we already menstrual physiology chapter, my friend John Batula. You must see the menstrual physiology chapter, and we have already done that. That menstrual physiology, I've taught you that the woman has the best fertility in the first 20 to 25 years of life. Then 25 to 35, it is still good. 35 to 40, much compromise. And after 40, it's only good luck. So after 45, you're asking about a 46-year-old. After 45, she cannot get pregnant. I mean, 99%. Yes, a lot of women have conceived spontaneously at 48, 49 years also. That has been shown. Even my own grandmother, she had a last child when she was 49. So yes, it does happen. One of my aunts is only around 4 years older than me. So yes, it does happen. But you must understand that those rarities. Common kya hai? Till 35 to 40, although compromised, that they can be pregnancy. After 40, chance is very less because the number of eggs is less. So after 45, like 46, you are saying, this lady needs eggs from a donor, sperms from the husband, and we can make a baby, and that baby can be put into the uterus. So donor eggs and sperm of the husband can be used to make this lady have a child. Can be done. She can get pregnant, but not with her own eggs. How to find answers? Know how to find answers. Okay, hysterectomy, myomectomy, please. Hysteroscopic. Yeah, yeah, hysteroscopic myomectomy. Yes. Yes, you want to see, Sudha? You can see. Hysteroscopic myomectomy, with the hysteroscope, you go inside. Ab kya hota hai na? When you go into the uterus, see, this is the hysteroscope, Sudha. You go inside like this, you cannot see anything. You have to distend the uterus. Hysteroscopy की class में पढ़ाएंगे आपको, ठीक है? You have to distend the uterus, then only you can see. So while you're doing this, all this water can you see bubbling, because along with the light, there's a lot of fluid going to distend the uterus. And then with my hysteroscope, you can see through the hysteroscope, this instrument is gone. So I'm seeing with the scope. The scope is somewhere here. This instrument is going through the scope to do the surgery. This is a hysteroscopic myomectomy. Very interesting. Yes, it is very interesting. Right, Jessica. Thank you so much. Is this screw myoma Doyen? No, no, no. It's not a Doyen's. Oh God, you missed a few things, Saman. We have Doyen's retractor is for a cesarean section, cesarean ka chapter. I think the team has already uploaded almost 80%, 70-80% of all the lectures of OBS also are over. Some few wrapping up is going on, guys. So I think the cesarean was already uploaded. Please have a look on that on the PW app if you've not seen. Doyens is for the retraction of the bladder during a cesarean. Myoma screw is for the myomectomy. Thank you, David. I hope all of you can gain with the discussion we have here. So we'll be waiting here for more questions, and you can always discuss with the PW team and my friend from Pakistan. And God bless you. I hope we can be in touch somehow, and you can also learn from the PW app. I'm very sure they have a way to reach out to you also. They will be seeing this. They're definitely seeing this and they'll reach out to you. All the best, guys. Bye-bye. Thalassemia minor, no. Thalassemia minor, it has an inheritance. It's a recessive disorder. So there's a pedigree. I mean, you'll have to see if only the mother is is having thalassemia minor and the father is not having, then the chance is very less than 25%, isn't it? So it is the inheritance you have to see. It's a recessive inheritance. At most, the child will be a carrier. At most, the child will be a carrier. That's all. He will not be having the disease if the mother has. If the mother is a carrier and the father is a carrier, then there's a rare chance that the baby may have thalassemia. So that depends on the inheritance. How to message? Yes, my number is there on all the apps. You can ask. I wish I could give it on YouTube, but what you can do is you can just write to PW team. They'll give you my number. They'll give you. I have given this freedom. I have some 15 groups wherever I have access to students. They make a group with me, and there are 15 big groups. They all have my number. So any group you can get in. We are regularly in touch, but that's a private thing. So I wish I don't have to talk about that here. What you can do is that you can write to the PW team. They'll give you my number. Anybody, yeah. Even my friend Majir from Pakistan can also do that. No problem. Right, guys. Thank you so much. Bye-bye.